Good morning, good afternoon, good evening to all of those who have joined us from various parts of the world as well as from India. We've received an overwhelming response for this conference with 5,000 registrations on Zoom, as well as a large audience attending us on YouTube. I, Dr. Girija Mahale, head Symbiosis Center for Emotional Wellbeing, and as the organizing secretary of this conference, along with Dr. Amrish Dharmadhikari, our co-joint organizing secretary from MPAR, a mental health initiative of the Aditya Birla Education Trust and our joint partner for this conference. On behalf of Symbiosis Center for Emotional Wellbeing, Symbiosis International University, I welcome you all for this very interesting two-day international conference on mental health for higher educational institutes with the theme, Raising Resilient Youth from University to Community. Well, I need not say how relevant mental health is given the overwhelming response that we have received today and the growing concern of mental health that we are seeing all around us. But through this conference, we wish to raise the hope that when mental health professionals, faculty, students, parents, and the management of universities come together and work together, we certainly can help our students become resilient to face the 21st century challenges. Because after all, when 5 fingers come together, the power of the fist is stronger than an individual finger. So let's hear the voices of all the relevant stakeholders in a university setting through this conference. Let's hear their expertise, their experience on what are the challenges that our youth are facing today and what are the possible ways in which we can collaborate and create a framework to help and support our youth for a better future. Without further ado, let us begin with our first panel of the day, which is Mental Health of Youth Global Scenario. And we truly have a global representation for this panel with 6 speakers from Canada, USA, UK, Hong Kong, Middle East, and Australia to represent this panel. Through this panel, we wish to understand the global perspective on mental health and understand what is the work that is going on all around the world to destigmatize mental illness, to support the youth, and to create a better future. Let me now, as the moderator of this session, introduce the panelists for today's talk. Our first panelist is Dr. Dilkhush Panjwani. He is the Assistant Professor of University of Toronto, Department of Psychiatry. He is the President of the Indo-Canadian Psychiatric Association. He has dedicated his career to helping patients without access to care and advocate to end the social stigma of mental illness. Great leaders need little introduction, so I'm not going to go through the entire extensive work that Dr. Panjwani has done, and he's going to speak through his work. Our second speaker is Dr. Samir Al-Adawi. He is the Professor of Behavioral Medicine at College of Medicine, Sultan Qaboos University from Muscat. Dr. Al-Adawi has interest in the biopsychosocial approach to the research and clinical services. He has published more than 200 articles in peer-reviewed journals. His body of knowledge appears to suggest that the social ramifications of psychological disorders are enormous in the view that beliefs and social networks that protect individuals from adjustment difficulties are severely challenged with rapid pace of urbanization and globalization. Very interesting. Dr. Anupam Dharmadhikari, our esteemed speaker from the UK. He is a consultant psychiatrist with extensive experience of working in India as well as the United Kingdom. Over the last 5 years, he's been working as the Director for Mental Health Division at the Birmingham Women's and Children's NHS Foundation Trust, UK, which leads a very innovative and radical youth mental health service Forward Thinking Birmingham. And we'll hear more about this as we proceed through the panel. Our fourth speaker, Dr. Claire Kelly. Hi. She is the Director of Research and Curriculum, Mental Health First Aid Australia. Dr. Claire draws both from an academic and lived experience perspective, having a history of depression and anxiety herself. She works extensively in international spaces, assisting overseas licenses to adapt and roll out their programs. We're certainly eager to collaborate and work with you, Dr. Kelly. And Dr. Sherry Chan, she is the Clinical Assistant Professor, University of Hong Kong. She is an extensive researcher with more than 150 publications in peer-reviewed journals, articles, and she's also written 3 academic book chapters. Welcome, Dr. Sherry. We are encouraging questions from the audience on chat. If time permits, we'll certainly want to ask our speakers, our esteemed speakers, to answer those questions. But if time does not permit us, then we will surely answer your questions during the conference as well as post the conference. So do post in your questions. We do look for as much as interaction as possible on a virtual platform. All right. So let me first begin with Dr. Anupam. Hello, sir. Welcome.
Hi, good morning.
Good morning. Sir, can you give us an overview of the mental health issues amongst the youth in terms of what are the statistics that we are looking at around the world, and particularly in UK, since you're working there and you've worked in India as well? And therefore also tell us, why do you think that youth mental health is so important?
Sure. Thank you very much for that. I would just like to begin by saying, first of all, that thank you very much for the opportunity to be here this morning, or at various time zones across the world. I'm absolutely thrilled to be part of this really esteemed panel. When I can, I know people have got really distinguished and decorated careers, and I'm really, really honored to be part of this panel. And also, I think the congratulations are definitely due by, I would like to commend the Symbiosis University and the Symbiosis Center for Emotional Wellbeing for taking a lead in this very, very important area. Youth mental health is something which, unfortunately, I would say had not received much attention until sometime recently. But this is an area which we definitely need to focus on as we go forward. There are various youth mental health services which are springing in various parts of the world, and it's really encouraging to see the kind of attention and detail the youth mental health services are receiving. More and more research is sort of going into this area, which is again very positive. What I would like to say is that, we all know the statistics of mental health in various ways. We all know that major depression is quite a significant cause of morbidity, and also a driver for significant disability in various ways, including physical health problems, where major depression can be quite a significant part. And we would all have read about, how various mental health problems are present in society, with various statistics attached with it. I think what is really striking when you read about the statistics of mental illness is how many years of disability people spend when they have got mental illness. And I'm purposefully starting with some more general information, but I will drill down to the more specific aspects of the youth mental health in a second. But yes, when you look at disability data, when you look at WHO data, it's very clear that significant amount of years are lost, or the impact of major depression and common mental health problems is very, very significant on people's lives. I think what is really concerning is that actually, despite of this, the burden of mental illness is quite hidden in lots of ways. So there are research studies to suggest that even in developed countries, you can have about 40-50% of people with mental health problems not receiving the level of care and the type of care that they require. Despite of there can be lots of barriers to still people being able to access mental health services. This percentage can be as high as 70% in some places in developing countries. And that is really concerning. Specifically in relation to youth mental health, and I'm conscious that we have got a limited time, but I'm more than happy to sort of share data with people if people have got any questions afterwards, or if they want to contact me afterwards. What we have experienced in the UK, I mean, there are a couple of national surveys which are done at regular intervals, looking at the adult psychiatric morbidity and also sort of mental health morbidity in children and young people. And it is very clear, and this is not just the UK data I'm talking about, but it is very clear that the mental health problems begin in they start in children in the adolescent years, and by the time somebody reaches the age of 25, if they are going to develop a mental illness in their life, they would most probably have developed that mental illness by that time anyway. So about 50% of the mental health problems start by the age of 15, and about 75% start by the age of 25. And again, I think that goes to show that early intervention is really important. I suppose we don't come to thinking about a 14, 15-year-old developing a mental illness, but the data is very, very clear. So we absolutely have to do something very early on in children's lives so that we can develop this early prevention, early identification strategies to support people, very early on to stop the mental illness from developing. So the primary prevention is really important aspect of this. There is number of...
Sure, Dr. Anupam. What I hear is that, yes, this is really the vulnerable age group. The 12 to 25 is the vulnerable age group for the onset of mental illness, for majority of the mental illnesses, right from schizophrenia, depression, anxiety disorders, substance use disorders for that matter. So taking on from there, I would like to ask Dr. Sherry. I was speaking to Dr. Sherry earlier, and she told me about the wonderful work that she's been doing in the recent times with the youth and the study that she conducted with university students more recently. I also want to understand what has been the impact of the pandemic on the students. I mean, and what are some of the specific mental health issues that you see in this young adult age group?
Thank you very much for asking the questions, and then I very much like to follow the discussions that Dr. Anupam has raised out. And then may I share a PowerPoint with you? This is the studies that we've done recently during the pandemic period in Hong Kong, and then you can see the background of my background. That is the University of Hong Kong. So we did a study in our university, the undergraduate students during May to August. That's the sort of between the second wave to third wave of COVID in Hong Kong. And then we recruited around 1,000 students from our university. And you can see that overall, the most salient results that we can see is that around 30% of students actually experiencing some form of a moderate to severe level of depression during this period. And then we can also see there's quite a lot of increase in conflict with family due to needing to study at home. And you know that Hong Kong is a very small area, and a lot of people are crowded living at home. There's a lot of change in sleep patterns, and then obviously very significant increase in time spending in study at home. And then we also see there's a significant relationship between the conflict of within family and the mood states. So that's we can see that's one of the important significant factors, particularly during the COVID period. And then also, just like what Dr. Anupam has mentioned, surprisingly, we see that a lot more students who experience moderate to severe type of depression did not seek help, has not really seeking help. And then overall, only about 26% of students actually sought any psychological or psychiatric help. And mostly, actually, you can see that a lot more people actually in the minimum or mild level of depression seeking help. So we see that, interestingly, people with moderate to severe type of depression, the major barrier to their seeking help is public stigma towards mental illness. Whereas the minimum to mild levels, it seems that the resilience level of resilience is the major factor, which that means that if they are more resilient, they have less tendency to seek help. If they're less resilient, even though the symptom level is less, but they will still go and seek help. But then the most concerning part is the moderate to severe type of depression patients, because they seem to have the barriers, the stigma is the major barriers to them. So I think to improve the help seeking social stigma is the main thing that we need to focus on.
That's very useful, Dr. Sherry. And I can share that even while working at our center here, we have some similar findings here that, certainly the pandemic has exacerbated the mental health conditions of the pre-existing mental health conditions of students who were already suffering from mental illness. And of course, the distress levels among students have certainly increased with increasing conflict, family conflict, increased online education, and the lack of social interactions that this lockdown has brought on. So thank you, Dr. Sherry, for sharing those findings. And you brought up a very important point of stigma. I think stigma to mental health has been there for years together. Yes, I see a growing awareness, as you can see that, large number of people are attending this conference. That itself speaks that people are more interested now, do want to know and understand mental health better. So I'd like to ask Dr. Panjwani here, because he's done a lot of work in mental illness and especially in destigmatizing mental illness. So, sir, can you also tell us, what are some of the signs that general public should look for to understand that the mind is troubled, especially in the youth, given their age, their, characteristics? How would you know if a young mind is troubled? And my second question to you, sir, is what can universities do, or what can education sector do to destigmatize mental illness? Thank you, sir. All to you.
Well, thank you very much for inviting me. There are 5 signs. I will make it very simple so that everyone understands, whether you are an expert or a student or an academician, professor. 5 signs which one should look for is fear or constant worry, anger and irritability, sleeplessness or too much sleep, low concentration or indecisiveness, and increased substance use, including alcohol use. So besides that, we look at patients from the biopsycho-socio-cultural and spiritual aspects. Spirituality is also important when we cope with this pandemic. So 5 self-care tips which I would suggest is build and keep a new routine every day. Reevaluate your expectations and set realistic schedules. Go to bed at regular hours and make up time for activities you enjoy every day. Eat healthy foods and exercise. Exercise is very important. When we are in lockdown or in social isolation, people tend to do minimum of exercise. Healthy food is another important, because when you are in the house isolated, your trip is to the kitchen. I counted my trips as more than 15-20 times a day. So one has to eat healthy, choose nutritious meals and drinks. Lots of water is important rather than drinking pop or caffeine beverages. Get outside, stay active, and avoid unnecessary exposure to people around you, because you wear a mask outdoor. If there's nobody, you don't need to wear a mask, but at least if you see somebody, keep a social distance, a physical distance of at least 6 feet, although it hasn't been proven whether 6 feet or 10 feet or 3 feet. Still, avoid excessive use of alcohol and other drugs. This is very harmful. This alcohol can lead to depression and many other illnesses. Connect with other people through telephone calls, through video chats, etc., email. Talk to your neighbors, help the elderly who are in the neighborhood, and set boundaries with email, social media, and media consumption. This is turning into an addiction nationally, all over the world. So one has to avoid restrict your media time, your blue screen time to minimum.
Yeah, that's very useful to know, sir, the signs of mental distress and what are some of the ways, very simple ways that you have shared for students to maintain their mental well-being. But what can be done at a university level, do you think, to destigmatize mental illness?
A stigma of mental illness. This is a social challenge. Stigma prevails in our society all over the world, even amongst doctors. So prevailing stigma of mental illness is one that needs to be dealt with. Ignorance, arrogance, and insensitivity about the mental illness amongst people. And these attitudes are the great public enemies of our time. And public education can be an effective antidote. Universities can have seminars like this, which you are conducting, and public education through pamphlets, through peer support groups. Stigma is very detrimental for everyone. And suicide is the most serious outcome of stigma. People do not want to seek help because of fear or shame. And when suicide happens, then suddenly everyone talks about stigma. So we have come a long way, but the work of perfection in eradicating the stigma attached to mental illness is scarcely done. So regrettably, in my opinion, stigma has outlived its obituaries. You see here the burden of mental illness in India. 1 in 7 Indians. This is a Lancet study on the burden of mental disorders across the states of India. 1 in 7 Indians, which is about 15% of the population, are suffering from mental disorders. This has doubled since 1990. And India only has 0.75 psychiatrists, not even one psychiatrist per 100,000 population. So the universities have to encourage this counseling. Access to counseling is the most important thing for students. Once a student has a private counseling, accessibility, universities here in Canada also have an accessibility program. If you're suffering from a mental illness, the university would provide you extra time to submit your assignments, as well as they would provide you with private, personalized, and confidential counseling, and also give you more time to write the exams. If you prefer a quiet room, that would be provided. So accessibility to patients suffering from mental illness. And whenever, it's very important that when we refer to patients or persons suffering from mental illness, we do not label them as he's a schizophrenic or he's a manic depressive. We say he's a person suffering from schizophrenia. And
Absolutely,
always
sir.
look at the positive side of a person. Everyone has a positive side to them. Talk. We also have a Let's Talk program, which happens once a year through Bell Canada and Canadian Mental Health Association. And people can call and talk about their illness. And as we come along, I'll come more things. And here you have the suicide rates. Suicide is the most important subject that we should focus on, because a loss of life, one life loss is too many. So family problems, failures in exam, love affairs, mental illness, illness due to mental, uh, total illnesses, marriage-related issues, and many others. The causes are not known. So male
Sure.
versus female.
Yes. Yes, Dr. Panjwani, that's absolutely useful information that you have shared. I mean, the statistics are really alarming. And in fact, WHO in 2020 says that 1 in 5 will have some form of mental health disorder in India. And yes,
Yes.
India is one of the leading, suicide is one of the leading causes of death among the youth. So it certainly needs immediate attention and urgent attention from the government. Thank you very much for sharing. And we did see through your slides, sir, that there are a lot of social and cultural determinants of mental health, especially among the youth. When we saw the suicide, causes of suicide among the youth, you did mention family problems, financial problems, unemployment, etc., as a leading causes among, as well as mental illness, of course, contributing to suicides. So my next question would be to Dr. Samir, who's done a lot of work in that area of socio-cultural factors. Dr. Samir, considering the youth, what are some of the socio-cultural challenges that this globalized world is posing for mental health?
Thank you, first of all, for inviting me, and I'm honored to be in this distinguished group. And most important, I think the organizer having this a noble cause is something we should all be proud to be part of. And thank you very much. So for the Gulf, the data suggests that in terms of demography, our population is actually pyramidal, means the bulk of our populations are very young. So we do have a very young population. In general, this this population here is a youthful in general. And there are some studies in the college-going populations, and there was some meta-analysis, international meta-analysis, and suggests for some reason the prevalence of mental disorders in this region outstrip other part of the world. So the reason was not really known, but partly because we do have such a population. So in my own work, we have been interested in looking how illnesses are experiences in a different culture. So we do these illnesses are highly indoors, but with peculiar manifestation. They are likely to say, yes, they have this if it has a somatic component rather than psychological component. That to say someone will admit that they have palpitations or, heart rate is high or something like that. But when it comes to this in mental health, what we call cognitive symptoms or psychological symptoms, they tend to downgrade they don't endorse those sort of symptoms. And we do have data emerging from the Gulf states, and Gulf states include Yemen, but there aren't any data. So my focus, I'll highlight the other one, Saudi Arabia, Bahrain, Kuwait, where I am, Qatar, Oman, Qatar, and Bahrain. So we see, for example, sleep disorders are 90%, very high among college-going population. And then when we ask them, when the studies inquire about depressive mood, that sometimes is quite low. So that suits our hypothesis when it comes something like a somatic, like, do you sleep well? Or although sleep is not somatic, but for example, anxiety tends to be highly indoors. The service in higher educations do exist, but the challenge is always like the instrument we are using, we don't know they have any cultural relevance. And most of my exposure to the literature here, even around the world, we tend to use this questionnaire. And usually they are inferior for clinical interview, and none of them have done that. And so that's the difficult part. The service themselves, because of the natures of presentation, these symptoms either will be, these kids will be, or these youngsters will seek help from a traditional healing system because the way they feel is, congruent with cultural setting, or they will seek help from with somatic symptoms. So sometimes you don't know you are dealing with heart disease or palpitation. So regarding stigma, this has been not widely explored in the college-going population, but it should be expected that mental illness is elsewhere in the world highly stigmatized. We know the pathways to care, as also suggests what is the trend, is that first people seek help within their own family setting, traditional healer, and by the time they seek help, it will be probably too late. Maybe their difficulty is more advanced, that sort of thing. So, and to summarize, the region where I'm speaking about today has a preponderance of youth. College-going population is high. Data suggests. What we don't know is whether the service that exists, which is a biomedical model or Western approach to mental illness, whether they are effective. So, maybe some colleagues here, we could communicate later how to proceed on this. But thank you for allowing me to share this short view.
No. Thank you, Dr. Samir, for sharing your expertise on what the mental health situation is in the Middle East. And Dr. Panjwani did bring up this very important point of the lack of or the dearth of mental health professionals generally all across the globe, and particularly so in India, with 0.75 psychiatrists per 1 lakh population. So on that note, Dr. Kelly, who works as the director of Mental Health First Aid, can you tell us a little bit about mental health first aid and how does it help in capacity building and the sort of work, amazing work that you and your team are doing there in Australia?
Hi, everyone. Thanks so much for having me here. So Mental Health First Aid is it's a series of programs now. So we have a number of courses that we offer, which is designed to help members of the public recognise when someone they care about may be experiencing a mental health problem or may also be in crisis. So probably the most common concern that people have in most parts of the world is, how do I tell if somebody might be having thoughts of suicide, and how can I support someone who is having thoughts of suicide? So we have everything that we teach is based on a series of guidelines that we developed using a consensus method called the Delphi method over many years, and we continue to develop those and refine those as we go. And it's really about recognizing some of those early symptoms, having a conversation that is kind, respectful, non-confrontational, and helping someone to recognize they may need help. Now, I think we're lucky in Australia in terms of the number of mental health professionals that we have, but it's not enough. It's definitely still not enough. And we also recognise that not everybody needs professional help. If a problem is sort of moderate to severe, then we definitely want someone at least to start by talking to a mental health professional. But for a mild and sometimes moderate condition, there are things that can be done in the community that actually help with that. Now, we always say that it's best that if somebody's been struggling for a while, that they do speak to a professional, regardless of how severe things are. But at the same time, it's an opportunity for someone to talk to a person they care about things like really the same sorts of things that Dr. Panjwani was talking about. How do we make sure that we get out into nature? How do we ensure that we're getting enough sleep, eating well, spending time with people, actually just connecting with people, which obviously has been very, very hard for the last 18 months and will continue to be so for quite some time. But also, once that connection has been made and a person can continue to support their friend, their colleague, their family member, then down the track they can say, okay, well, look, you've made these changes, and what I'm noticing is that things don't seem to be getting much better. So can we come back to the idea of talking to a professional about it? And because that rapport has been built up over time, it's less confrontational. Now, obviously, with the incredibly high rates of mental illness in young people, and really when in Australia, when we look at our 16 to 24 year cohort, and knowing full well that it is probably worse now than it was 18 months ago, but we around over 1 in 4 16 to 24-year-olds in Australia probably has one of the common mental illnesses. So that's depression, anxiety disorders, and substance use disorders. And within anxiety disorders, we are still counting obsessive compulsive disorder and post-traumatic stress disorder for the meantime. And it's actually useful to, I think that there's the concern about depression is really important, but actually in Australia and in some other parts of the world, for young women, post-traumatic stress disorder is more prevalent than depression. So that is a great concern for us indeed. But we're looking at a little under 1 in 4 young men and almost a third of young women who have a mental illness in any 1 year. So obviously those numbers are enormous, and that represents a huge burden within a time period where people are establishing who they're going to be as adults. They're finishing important developmental stuff, especially neurologically speaking, where a lot of the pathways that will determine how the brain is operating for life, essentially, we're creating those pathways. But at the same time, we have a wonderful opportunity at this age to change that thinking. Now, one of the things that we see is actually mental health first aid does not focus on stigma. We don't say, hey, stop having these bad thoughts. It doesn't actually, we know in public health that just makes people say, I'll do what I want. But what we find is that by sharing accurate information in accessible language, we see huge improvements in stigma. So it's about giving people the information and letting them change their minds themselves. So we get really terrific results that way, but we are also setting up a community norm where it's okay to talk to somebody you're concerned about. I know that these things can be very cultural, and I know that a lot of Australians are raised not to be nosy, and you think that means you shouldn't ask somebody if you're worried about them. You should just don't highlight that, just leave them alone, be respectful, but actually saying, hey, I'm concerned about you and I'm too concerned about you, I care too much about you to just pretend that this isn't happening. That we're actually setting people up right from early high school to actually be able to have those conversations. And in fact, some of the most groundbreaking work that we're doing in Australia is with those a little younger than tertiary setting, where in high schools we are directly teaching suicide intervention skills. We're teaching kids to recognise the signs that a friend might be having thoughts of suicide and providing that direct peer support and getting an adult involved as quickly as possible. And Dr. Panjwani may know that we actually have mental health first aid in Canada. It's been running for many, many years, and the UK as well, and in fact in some parts of the Middle East. And Hong Kong was actually the very first country outside of Australia to take the program on. So I feel very privileged to be in this group right now.
That's amazing work, Dr. Kelly. Really, I guess using the right language and being very empathic with people who do suffer from mental illness is such a key thing that you've just shared.
Can I just add one point here?
Yes.
We have a Mental Health Commission of Canada, and they have also introduced the Mental Health First Aid Program, which, of course, tries to improve the mental health literacy amongst people, provide the skills and knowledge to help people better manage potential or developing mental health issues. And they can help themselves, their family members, or a colleague, or the community at large. So I think we have, from one end of the world to the other end of the world, we have mental health first aid programs. And I think many countries should develop their own, modify it to the needs of the population. Universities agreed, again, can take the initiative in starting this mental health first aid?
Yes.
Thank you.
It's actually in all the countries where the program has spread to. It starts off actually with a license, and then we assist them to adapt the materials as needed to suit the community. And then, of course, there's language as well, and obviously, you know, in Canada, the need for French translations of things, and it just means that we've got this model that works really, really well, that we know works really well, but everyone can say, okay, so for our community, we need these changes, and it creates something that is unique to the community.
Yes. That's
Talk
wonderful.
globally, go global and act local.
Yes, yes. And in fact, we're in 25 countries now, and we've trained over 4 million people across the world.
Thank you.
So it's a wonderful thing to be involved in.
Nice
Wonderful
to
to
see
hear
you.
you. Yes, so Dr. Panjwani, I was just about to come to you, and we recently heard your webinar on, you conducted this beautiful webinar on building resilience. And since that's the theme of our conference, can you tell us what is the role of resilience in mental health, and how can universities promote resilience or develop resilience within their setting?
Amongst individuals,
Yes.
these are the factors that count onto building resilience. Sociability, you form healthy relationships, optimism, you view yourself and the future in a positive light, flexibility, adapt to change. Change is part of life, so we need to adapt to change. Self-confidence, move towards a certain goal, base decisions on confidence in one's own ability and on the ability of the community. Competence is something to be good at something and take pride in it. Even if you're doing something very simple, take pride in it. Insightfulness, understand people and situations, be empathic, be compassionate, be able to see the other sides and the other people's point of view. Perseverance, never give up. Perspective, view crisis, especially the COVID crisis, as challenge to be faced, not insurmountable obstacles. They don't see them as obstacles, see them as challenges. And self-control, manage strong feelings and impulses, internalization of locus of control. You have to take the control within yourself. So that's building resilience. And for communities, for a community to be resilient, its members must put into practice early and effective actions. If you just keep waiting, maybe things will change, that won't help. If residents, agencies, and organizations take meaningful and intentional actions before an event, communities can re-establish stability and after the event has actually occurred.
I'll move forward and ask Dr. Anupam about his unique program of Forward Thinking Birmingham. Can you share some of the practices and systems that have been established to support youth mental health?
Sure, excellent. Thank you very much for that, Dr. Mahale. So what I would like to say is that, we've spoken about youth mental health, and we've heard from different panel members about their experience of working in this field over the last sort of half an hour, 40 minutes, which is really exciting. I would like to just share our experience of youth mental health service in Birmingham, which is called Forward Thinking Birmingham, which has been up and running for the last 5 years now. And the reason for FTB becoming, sort of going live 5 years ago, was the fact that there were a number of challenges which had been identified in the areas of youth mental health. So in the UK, generally the services work as child and adolescent mental health services up to the age of 16, 18. And then you have got adult mental health services starting at the age of 18. And that's like a traditional clinical model of the way the mental health services work. What we have spoken about in terms of the difficulties young people, children, adolescents, young adults experience, I think the key aspect of this is to sort of make sure that the services are integrated, they work very, very closely with each other, so that people who are accessing mental health services have a very unified, very seamless experience of mental health services. I think one of the biggest issues in mental health is as I said, if the intervention does not happen at the right time, there is a risk of problems becoming more entrenched. And the secondary prevention and tertiary prevention becomes quite a significant challenge then, because people lose their lots of years to disability. So the important aspect is to maintain continuity of care. And as I said, I can share my experience with people. I mean, in the interest of saving time, I'm more than happy if people want to speak to me afterwards so that I can give you more information. But there are a number of things which we have done as part of Overthinking Birmingham. We start right at the age of 0. So we have got very well established infant mental health services. We believe that it's really important to look after young women who are becoming pregnant and who have got various risk factors, either for developing mental illness themselves, or they come from environments and circumstances where it is likely that infants and young children will develop mental health issues as a result of that. So we believe in starting really, really early. So our services start at the age of 0, as I said, and they go all the way to 25. And we integrate those services very, very closely with each other. Because as I said, one of the issues with mental health services is the accessibility, and that becomes a really difficult problem then. We work with young people, we collaborate with them, we co-produce our services with them, so young people actually decide as to what type of services they want, and they can actually decide structurally as how the services should look. And I'll just make one final point before signing myself off, is the work that we do with the University of Birmingham and other universities in Birmingham. We've got a population of about 100,000 students in the city, and every single student is really important, because the type of support and care they receive when they are experiencing mental health challenges is going to determine as to what sort of outcome they're going to have in terms of their educational attainment, in terms of work, in terms of their future life. So we really believe in supporting every student, and we work very, very closely with university wellbeing services. So these are just some of the principles that we follow.
Sure.
There's a lot to talk about in there, but as I said,
I do know. Absolutely, sir. So key points that I take from what you just said is start early, start from a very young age. Bringing in that awareness and early detection is extremely important. Creating a user-friendly model, especially a youth-friendly model where there's easy accessibility, easy approachability, and a collaborative approach where the user has the choice of selecting what sort of services he wants to take up. That's very, very important, Dr. Anupam.
Sorry, just one final point. I would just like to say that the mental health intervention does not happen in psychiatrist offices.
Exactly.
I think the mental health interventions happens outside in the community. We have to take the services out to people, and we have to work with everyone: education, schools, universities, police services, and with families and with communities. It's mental health interventions. I mean, I strongly believe that they do not happen in boundaries within the walls of secondary mental health services. They should be taken out into the community. Just one final
point. Absolutely. The integration of services is absolutely important, and involvement of all the relevant stakeholders is crucial. Speaking of early detection and intervention, I would like to ask Dr. Sherry, since she's done a lot of work in assessing outcomes of people with long-term and chronic severe mental illness. So what do you say about, can it change the trajectory of an illness? Does early intervention and early detection, can it change the trajectory of mental illness?
Yes, absolutely. I think early intervention paradigm has been around in the last 30 years. And at the very beginning, it started off with early intervention for severe mental illness, such as psychosis. But now it's already moving towards mental health or mental illness as a whole, because we believe that at the very early stage, the symptoms are very heterogeneous. It's very difficult to detect whether it's a psychosis or whether it's any other form of psychiatric conditions. But our evidence suggesting that we can see from this slide, just one slide, this one is that our 10-year or 12 years follow-up studies of early intervention services, people has gone through the early intervention services for psychosis, very impactful outcome is a reduction of suicide. I think that's a very important evidence, as mentioned previously, that suicide is the key problems or key. Another point I wanted to point it out is that because of the effectiveness of early intervention, we also started to develop an overarching community-based service for youth mental health. And for those who are interested in our current model, you can go onto this website. It's called Level Mind, and it's gathered to with 7 to 8 NGOs in Hong Kong, with the university, with the 3-tier step care services, from tier 1 engagement to therapeutic interventions to individual caseworks. So we hope that this sort of expanding the early intervention to general youth mental health can actually even further improve our mental health conditions of the youth and also the long-term outcomes.
Sure, Dr. Sherry. That's a very crucial point that you've mentioned, that the impact that his mental illness can have on in terms of productivity and the economy of our country. And therefore, the investment in mental health needs to be done through the various agencies, whether it's non-governmental organizations, governmental organizations, so that we can achieve the outcomes that we want to achieve for a better economy. Thank you so much, Dr. Chan. Our last 2 questions for our 2 panelists. One would be to Dr. Kelly. She did speak, she's done wonderful work through MHFA in also creating peer support groups. And youth voice is very important. When we talk about youth mental health service, we cannot neglect the voice of the youth. And so, Dr. Kelly, can you share and elaborate on the peer support program, please?
It's actually not peer support groups, it's peer support training. So it's where we recognise that overall young people don't really want to go immediately to an adult about the concerns that they've got. Of course, adults don't understand anything. It's the way that it goes. But it's really about, we know that young people will often support each other, but they will do that in a way that's not appropriate. They will try to take too much on themselves, especially if they already have their own difficulties. We know that those young people who are highly depressed or highly anxious are most likely to really intensively support a friend, which isn't good for either of them. So it's really about recognizing that when everybody in a community has some understanding of what to look for, that the right person is probably going to be there to have the conversation at the right time. So it's less about peer support groups where in the long term people who do have a problem may be able to come together and support each other. And really we're seeing such a huge rise in the peer worker space in Australia, which can really help to improve access to professional help when there's not enough of the very highly skilled mental health clinicians. It is a really good option with good evidence behind it, but recognising that the first step to seeking help from an adult probably won't happen because a young person says, "Oh, I'm having some problems," and I might find an adult to talk to. Yes. So it's that's exactly where we're going with it, and we've had wonderful outcomes so far in high schools and in university settings as well.
Yes, I think that's very crucial for universities to have such peer support training and peer support groups so that the youth can support each other in these difficult times as well.
And I think that there's a lot of assumption that I'm not coping, but everybody else must be. And it's just not true. The sort of pressure that young people put on themselves, once the conversations start, we can recognise that it's actually a lot more common. Some of your friends are being affected by it right now, and that helps to improve self-stigma. So that feeling of I'm so much worse than anybody else.
Yes, and our youth are really, really, so proactive when it comes to their own education, their own life. We would really encourage our students to, provide that kind of a support network for each other during these difficult times as well. And that brings us to the very last question of a student culture on the university setting. What we are observing over the years is while, education and knowledge is growing and children are more and more intelligent these days, there is a lot of unhealthy competition. Children are more on the social media, more and more of social isolation that is grappling them. So what would you say, Dr. Samir, as a professor of behavioral medicine, what are some of the tips that you would like people to take away from here to create a healthy student culture?
Yeah, it's not easy because, for example, the way we quantify mental health in the region is based on, say, Western view about mental health. But if we develop our own, it may turn out to be, you hamper that much require international, comparison. But what to be done, I think some of these have been alluded very well earlier. We have to try and, many technique and see which one is likely to be, suitable for that particular population. For example, some of our studies in the Gulf have suggested there is a gender issue, like it's mostly, these coping difficulties are mostly common in female. So those are likely, they should be subjected to, early interventions or, pathway to care. They also have shown that people from urban, rural area, they cope better. Although these colleges are in, urban setting. So we need to understand maybe like people with social cohesions or have a family stability, maybe some economic issue, that could be a protective factor that we could enhance and also to use as a mechanism for prevention. So that's my view.
Sure. Thank you. So I hear that, creating equal opportunity for students at our university settings, communication happening between faculty, students, staff, and having those connections, building those connections within the university, having a stronger network and building the emotional resilience, emotional quotient of students would be the way forward. Thank you all for this wonderful discussion. Thank you each and every speaker for giving your valuable time. Dr. Panjwani, especially for joining in.
I have a take-home message for
Yes, sir.
students.
Sure, sir.
We should not give up and we should not allow the problem to defeat us. Learning gives creativity, creativity leads to thinking, thinking provides knowledge, and knowledge makes you great. So all of you should strive in knowledge from whatever you want to, wherever you have to go, get knowledge. And this is from our beloved President Abdul Kalam. Mental health crisis which has happened, it is our collective responsibility to nurture and invest in mental health initiatives to improve the quality of life of people with mental health. So through education, equitable and accessible mental health care, better livelihoods, creating infrastructure, and effective public-private civil society partnership. This is what is lacking in many countries. We have to have a government cannot do everything. We have to have the business, private organization, as well as civil society, NGOs, collaborate in a very effective way. So that's the take-home message.
Beautiful.
Thank you.
Thank you so much, sir. All right, we did have a few questions that have come in, but because of lack of time, we will answer them though through this conference and get back to you soon.